Improvising, Jackie. So just a little update on what's going on across the BHF Data Science Centre. So for those of you who aren't familiar with us, and as many of you know, we were forged as a partnership between HDI UK and the British Heart Foundation, British Heart Foundation being the major funder of the initiative, to become the sort of cardiovascular component of HDI UK embedded within HDI UK. And we started out at the beginning of January in 2020, so just before the pandemic actually, and really therefore the vast majority of our work in the first couple of years was conducted after we'd all been plunged into the pandemic. And our remit is essentially exactly the same. Our vision and our mission are really very similar to those of HDI UK, except all through a cardiovascular and increasingly now cardiometabolic lens. You'll recall, of course, that HDI UK and therefore the BHF Data Science Centre focus on three major activities: bringing health data together across the UK and actually increasingly internationally as well, improving it through the application of a range of different tools and methods, and enabling its use for a very broad range of research discoveries. And all of that done, of course, through a series of partnerships with, most importantly, patients and the public, but also practitioners and research users across a very broad spectrum. So as far as the centre is concerned, we have got a number of thematic areas of activity, and you can see them on this wheel here or listed down the right-hand side. So work around the use of nationally collated structured coded data, which has really been epitomised by the work we've done through the CVD COVID UK COVID Impact Consortium, which many of you are members of and key contributors to, working with data through made available through national TREs. And perhaps the most important component of that work has been the work we've done in partnership with NHS Digital to kickstart their trusted research environment, which has now become very much part of their service, which they're continually enhancing. But we have a number of other thematic areas of activity, and I'm going to return to these later on, after I've just talked a little bit about the first thematic area, just to give you a sense of the broad spectrum of our flavours. So all of that activity requires quite a large team, and we've been, during the course of the first couple of years, but particularly over the last year or so, been assembling that team. So as director, I'm lucky enough to have a number of other senior scientists across a broad spectrum of different areas of specialisation, who are seconded in, each of them a day a week, to act as our associate directors for the various thematic areas of the centre. So you can see we've got Matt Sides, who's Professor of Clinical Trials at UCL, who leads on data-enabled trials. Michelle Williams, who's a radiologist based in Edinburgh, leading on unstructured data with a particular focus on imaging. Spiros Danaxis, who many of you will know because he's been involved with our consortium from the very early days, working on leading on computable phenotypes. Richa Sofat, again, a very active member of the CVD COVID UK COVID Impact Consortium, who's our lead for enhancing cohorts, and has recently moved from UCL to take up a chair at the University of Liverpool, and she's a clinical pharmacologist. Tim Chico, who is a cardiologist. In fact, he's the only cardiologist amongst our set of associate directors, and he's based at the University of Sheffield and leads our thematic area on personal monitoring data. Ewan Pearson, who's our recently appointed associate director to lead on our diabetes data science catalyst, established in partnership with Diabetes UK. And our most recently appointed associate director, but actually she's been an active member and taking on leadership roles in our CVD COVID UK COVID Impact Consortium from the very early days, Angela Wood, who's based at the University of Cambridge and is a biostatistician. So we've got great spread of expertise amongst our associate directors. None of that would work without our fantastic operations team, which is led by Lynn Morris, who many of you have met. We have two fantastic project managers, Jackie MacArthur and Reuven Prieden, and many of you have met them as well, at least online. And then two newish members of our team, Kate McAllister, who's leading on comms and events, and Samara Khan, who's taken on management of our PPIE activities. And also a new member of staff in the last few weeks, Annette Jackson, who's our new executive assistant. And then finally, but certainly not least, our growing health data scientist team, led by Tom Bolton and John Nolan, and now we are starting to grow that team. So the latest members of that team are Mehrdad Mizani, who's started just within the last few days. He's the very newest member of our team, and soon to join us will be Zach Welshman, and we're making further additions to that team over the coming weeks and months, recognizing that providing data management and data curation services, particularly within the national TREs, but actually across a range of other areas of activity, is really critical to helping researchers hit the ground running. So just giving you a whistle-stop tour then of what's been going on in the area of access to and use of nationally collated, structured, coded data. And of course, this is absolutely a team science. And the vast majority of people on this call have been involved in one way or another in this work. But you'll recall that at the start of the pandemic, there wasn't a trusted research environment in England that was making data available for the entire country's worth of various linkable health data assets from a multitude of different sources. NHS Digital had for some time been on the cusp of setting one up, recognizing that this was going to be a really helpful way of making population-wide data securely and appropriately available without its dissemination to multiple different research organisations around England, the UK and beyond. And trusted research environments for this type of activity already existed in Wales and Scotland and had for some years prior to the pandemic, and indeed they were starting to become victims of their own success, particularly the National Data Safe Haven in Scotland, which had quite a backlog of applications. And indeed, during the course of the pandemic, a trusted research environment has also now come into being for Northern Ireland. They did have one before operated by the Honest Broker Service, but it's been substantially improved. New data assets have become available, and they've set up remote access mechanisms as well. So we now really have a growing network of national trusted research environments to hold and make health data available, and all of them are improving all the time. And of course, alongside this, there are various other trusted research environments making data available for large subsets or the whole population, and in particular the ONS holding data from outside of the health service as well, highly health relevant data. So this is not a complete picture, but it's the bits of the picture that we've been interacting with most. So just focusing on the NHS digital environment, which in many respects has been the most transformational because of the size of the population and the ability rapidly to populate it with a wide range of data sets from multiple different sources. And many of you will have seen this slide before, and many of you will have contributed to this initial description of the data sets held within that environment, which have increased over time. And of course, many of you are using those. So this shows the data sets provided by NHS Digital and sourced from outside of NHS Digital, COVID-19 relevant data, a whole bunch of generic data sets from hospital, death registries, primary care, community dispensing, and other sources. And then specialist data sets, which during the course of the pandemic have increasingly started to flow into NHS Digital, enabling their linkage to these other generic data sets and adding value in both directions. And in our case, the focus has been on the cardiovascular data sets, but of course, there are many other disease-specific data sets, and some of those are also starting to be made available through the NHS Digital Trusted Research Environment infrastructure, not least the cancer registry and associated data sets that DataCan have worked very hard on making available. And we're aiming in the next few months to actually bring these two DataCan and BHF Data Science Centre environments together in preparation for HDR UK's next quinquennium. So of course, statistically powerful to have all this information, comprehensive through linking data sets together from different sources, and inclusive of pretty much everyone in the population, which is a good way of creating a picture of what's going on in a way that many research studies that require active participant have tended not to be able to do because of the underrepresentation of particular groups, especially those from socially deprived backgrounds, ethnic minorities, and those who are often the least healthy. So through bringing together this picture, we've been able increasingly to cover parts of the population, and some of what I'll share today is work that's involved either England or England and Wales, or in some places England, Wales and Scotland, and through the work of the Honest Broker Service and Reuven Preden working to incorporate Northern Ireland into part of the what we can offer through this consortium, we will soon be working towards a 4 nations view. So lots of projects going on, lots of people contributing. And I think one of the good things about doing this has been the partnerships and the team science ethos that's really been very much a part of this, but also making the data, getting through the bureaucratic process of being able to access the data, and then being able to do that for a broad program of work that many people can contribute to, so that there's one painful process rather than multiple painful processes on the access side of things. I'm not going to talk about all of these projects, but this is really just to encourage you to have a look at some of the outputs, and Reuven summarizes them very nicely on our web pages, but also to engage with any of these projects that are still ongoing, and many of them are, that might be of interest to you, and to think about other projects that might be complementary to or add value to what's already going on, because there's certainly a lot more to do beyond what's already happening. So just as a quick overview of some of the ways in which the data within these trusted research environments has been used, and these are some illustrations of some of the earliest work that came out from the English environment, largely descriptive, showing that over just 10 months during the first 10 months of 2020, with a population of this size, very large numbers of incident outcomes, in this case stroke and TIA on the left, and myocardial infarction on the right, accrue, and that it's only by linking data across multiple different sources, in this case primary care, hospital admissions and registered deaths, that one can get a more or less complete picture of all of the events that are accruing over time, because they are not all captured in any one single course, in any one single source, and significant subsets are captured only through one of these sources. We hope to be incorporating some of the specialist registry sources into what will become then 4-part Venn diagrams to show the added case ascertainment value of these additional sources. And you get a very similar picture when looking at COVID-19 infection status from this work that was led by Johan, Chris and Spiros in the UCL team, with many others contributing as well, showing really very nicely that only one source of COVID-19 infection status is not going to be enough. And of course, we had very little testing early on in the pandemic, and then later on, a significant proportion of cases of COVID-19 were captured through testing systems alone and were not presenting to healthcare. And again, this is work from Johan, Chris Spiros and others, just illustrating how when one looks at these different sources of COVID-19 infection status and how people were picked up and diagnosed and where they were managed, the mortality picture, of course, is very different, indeed, across both waves of the pandemic. And one of the things that interested me was how it was possible to pick up patients receiving intensive care with COVID-19 infection who weren't being managed inside intensive care units. And I'm sure that the work that Chris and others are leading on now to look at how the data from ICNARC adds to this picture will complement these analyses. But you can see, and perhaps this is somewhat unsurprising, that those receiving critical care but outside of the intensive care unit have had substantially the worst mortality prognosis, whereas those with a positive test but not presenting to healthcare at all have had by far the best mortality prognosis. We've also, and again, this is work done by a large team with Will Whiteley, Jonathan Stern and Angela Wood at the helm, but a huge number of contributors from across the country. And this shows the effects of COVID-19 infection on major arterial and major venous events over time. It shows how when you have very large numbers of events, and there are several tens, if not hundreds of thousands of these events in this very large population, you can study subsets of the population. You can look in different age groups, you can look in hospitalized and non-hospitalized individuals, and you can look over time with some detail. And because of the multiple linked data sources, it's been possible to adjust in this cohort analysis for a wide range of confounders. So this shows just at a high level the results of the analyses for these outcomes, arterial events being dominated by MI and stroke, and venous events being dominated by pulmonary embolus and deep venous thrombosis. And you can see for both the very high early excess relative risk of both arterial and venous events falling quite rapidly over time, far more rapidly for arterial than for venous events. So the relative excess risk is prolonged for longer for venous events and declines somewhat more slowly. The relative risks on the whole are higher for hospitalized than non-hospitalized individuals with COVID-19 infection. And that the risks do seem to stay elevated for a prolonged period of time, right out in these analyses to 44 weeks, where a hazard ratio of 1 would suggest no elevated risk, and clearly they're staying well above that line. Now, some of that prolonged risk over time could be due to residual confounding. But the fact that we have these different patterns for arterial and venous events, and that particularly for venous events where they stay more elevated for longer, we think that at least some of that effect is real, and that these risks really are prolonged for quite a considerable time. And then, very importantly, it's possible with very large populations to study rare events. And one of the examples of that really coming into its own is the ability to study the rare adverse effects that may be associated with vaccination, in this case, COVID-19 vaccination. So here we were actually particularly keen to look at some of the rare clotting events that were being reported in association with AstraZeneca vaccine. And we looked up to the time point before they had started to be reported to try to understand without bias what the excess risk of some of these events might be in people who had had vaccine or after vaccination, looking within the first 28 days of vaccination and then from 28 days and beyond. And here we started out by looking at the large categories of venous and arterial thrombosis defined as on the previous slide. And we threw in lower limb fracture as a sort of control outcome, and I'll come to that in a moment. So you can see in the blue the results for the AstraZeneca vaccine, and in the red the results for the Pfizer vaccine, the two vaccines that were in use at the time that these analyses were run during 2021. Very large numbers of events because of the large population, split into younger individuals under 20 and older individuals 70 or older. And what you can see for both venous and arterial thrombosis is a tendency for a reduction in the risk of both of these outcomes after vaccination with either vaccine. It's less convincing in the under 70s for the AstraZeneca vaccine, but otherwise the patterns are broadly similar across both of these sets of outcomes. Now, if we look at lower limb fracture, which we wouldn't expect to be affected by vaccination, then you can see in the under 70s, there does appear to be very little effect of vaccination. In the over 70s, we are seeing some effect, and that may be an indication of some residual confounding, but it does look as if we are willing to trust this as a control outcome, that the control of confounding was relatively good in the under 70s. So perhaps we can be more confident in the results in the under 70s than in the older individuals. And I guess the other thing to say is that we might expect, of course, to see at least some reduction in venous and arterial thrombosis following vaccination, given that we've already demonstrated that COVID-19 infection, against which vaccination protects, is associated with these thrombotic outcomes. So, of course, the larger population really becomes much more important when looking at rare events such as intracranial venous thrombosis and hospitalization with thrombocytopenia, both of which, as you can see here, at least in the under 70s, have an increase in relative risk following vaccination. In the case of intracranial venous thrombosis, particularly at least with more confidence within the first month of vaccination. So in both cases, an approximate doubling of that relative risk. It's really important to set that into context. Of course, these are extremely rare events, and we've seen these increases in risk only with the AstraZeneca and not with the Pfizer vaccine. So that sort of fits with the suspicions that were raised by yellow card reporting in the UK and similar types of reports in other countries. But the background rate of hospitalized intracranial venous thrombosis prior to the pandemic was only about 3 million cases per people per month. So if we double that and it goes up to about 6 cases within a month, then that rate is really increasing by only about 3 cases per million in the month post-vaccination. So it's very small compared with the benefits of vaccination, and important to set it in that context. And then finally, we were also able to look at myocarditis and pericarditis. And this is work that's been led largely by Venetia Walker, based at the University of Bristol, again, though working with a very large interdisciplinary team with many individuals involved. And in contrast with the results that have come from some other studies looking at myocarditis and pericarditis in the context of first and second dose of both AstraZeneca and Pfizer vaccine, where others have generated, particularly in younger individuals, a signal for Pfizer vaccine after the second dose, we didn't see such a signal in our analyses. I've shown the overall analyses here, but we didn't see clear evidence of different effects by age or by sex. Whether that's due to different methods, whether it's because of larger numbers, whether it's because of some potential biases in other types of analyses that have approached this, is uncertain. But I think it's quite interesting that we didn't see evidence of a clear effect here. And then finally, some work led by Richa Sofat and her team, which shows that it is actually possible to run analyses across several different countries in the UK, in this case, looking at dispensed medicines. And these analyses have only really become possible at this scale because of the availability of data on dispensed and or prescribed medicines in Scotland, England, and Wales now, which is new in the last year or so. And you can see here the very dramatic falls in dispensed medicines from the perspective of antihypertensives, lipid lowering, and oral anti-diabetes medications after lockdown, after the first lockdown, with some but not complete recovery. And so some of the people who would otherwise have started on these medications may have never started on them. Reacher and team did some projections to work out what number of events might occur as a result if those people remained off these medications and didn't catch up. And you can see large numbers of potentially avoidable strokes, heart attacks, and other vascular events as a result of this under-prescribing and under-dispensing of medications. Luckily, prescriptions and dispensed medicines with respect to insulin carried on. So it's certainly become possible during the COVID-19 pandemic to do this sort of research that's really of significant clinical and policy relevance across the UK now, using these rich, diverse, linked national health data. Having a TRE for England in the mix to create that very large population effect has been a critical enabler. It's been really important to demonstrate that it's possible to run studies across more than one country, creating the increasing possibility for the future of making that a more efficient and streamlined process so that we can rapidly generate UK-wide insights using these types of data. And I've shown you a few examples of the types of studies and insights that we've been able to generate, and that's a subset of the outputs. And so a big thank you to all of those who've been involved. It's been a huge team effort and a real privilege to be involved in it. It's very important to have that team science approach, of course. The sort of national coordination is important, but I think most important of all is maintaining the true involvement, engagement and support from patients and the public. And our Approvals and Oversight Board has been lucky enough to have some really great inputs and insights from our public partners. So I just want to give you a quick whistle-stop tour of the other areas of activity in the Data Science Centre. So without going into detail, because I can't do it justice, and I would like you to hear in subsequent seminars from the individuals who are leading on these areas of work, we have this theme on better access to and use of unstructured health data, focusing on imaging. This is led by Michelle Williams with fantastic support from Jackie MacArthur and other members of the team. And we have held some workshops engaging with members of the interdisciplinary scientific community. Jackie and Michelle are jointly conducting a Delphi prioritization exercise to help guide the research questions that are going to be of most interest and the research modalities. They've been doing some work with members of the public to create some front-facing public and patient accessible materials to describe the various different ways in which imaging is used in cardiovascular research, and a number of other activities. So watch this space, there's a lot going on, and there'll be more to present on this, growing all the time. Next, our area on personal monitoring data, which Tim Chico is leading. So Tim is increasingly well connected with a number of companies and physics and engineering experts working in this area, both in the area of app development, in the area of the use of apps for a range of different research and healthcare purposes. And we're doing a lot of work at the moment focusing on how we might link data that's potentially linkable from apps that people are wearing in the wild, which becomes suddenly vastly enriched from a research and potentially clinical care perspective if they're linked into health records. And we're looking at how we might work with national data providers such as NHS Digital, companies like Apple and Google, and the NHS app for obtaining information on NHS number for linkability, to actually make that into something of a reality and starting some pilot work in that area. Computable cardiovascular phenotypes, so that's how cardiovascular health is represented in computable form. And Spiros is our lead for that, and he does very nice illustrations of how multiple Lego blocks, which might be considered as being all the computable readable components of somebody's healthcare record, can be spliced together algorithmically to form a picture of disease status or indeed severity, date of onset, and the certainty or probability that we have an accurate readout there. So there's a lot of work going on in that space, and in particular this area is very relevant to a number of the other areas of activity, not least the structured coded data area and cohorts and trials. Reacher, who's leading on enhancing cohorts, is working hard now with potential providers of a new platform that we want to set up in the coming months to support cardiometabolic cohorts, so disease-based cohorts, to link their data to healthcare data from national custodians across the UK, and to make their data securely available to external researchers. So a trusted research environment to support all of that activity, which will be trusted by the data custodians, who then, with the consent of the participants and the trust of the data custodians, we should it should make it much easier for people to link in data for the prospective follow-up of their cohort participants. So that's a watch this space activity. On data-enabled clinical trials, Matt Sides is leading a number of strands of work here to try and really increase the number of cardiovascular clinical trials who are aiming to and can, in actual fact, use routinely collected healthcare data sets, mainly for follow-up, but also potentially for planning of trials as well, through providing better guidance, bringing together communities to develop best practice, some targeted driver project activity, and we're working with quite a lot of specific trials there. There's a group come together to develop standard outcome definitions and code lists with particular relevance to trial activity, and we're working with funders, NHS DigiTrials and others to try and feed into and improve and help streamline their processes. And then finally, we have this new initiative, which is about to be launched publicly, and we've already got Ewan Pearson up in Dundee now working as our Associate Director for this Diabetes Data Science Catalyst, which is a new initiative that's taken some setting up, but now delighted that Diabetes UK is working in partnership with us and the BHF to provide some additional funding to allow us to support across all our thematic areas of activity, health data science with relevance to diabetes, and particularly the intersection between diabetes and cardiovascular disease.